Good morning, Rise. I am Amanda Duncan, Academic Project Manager at Georgian College, and welcome to Day 3 of Rise. I hope you joined us yesterday when we heard from our local entrepreneurs discuss the differing social and economic impacts of COVID-19 pandemic, and importantly, received some context and learned about the importance of acknowledging our Indigenous population in history. Today, we're going to shift some gears away from entrepreneurship and business towards mental health, wellness, and social intervention. If you were with us at 9 a.m. this morning, you would have done our yoga class with Megan Kurt Chang, and you're ready to take in today's session. But before we start, I'd like to turn the virtual stage over to Laura Moote to give our land acknowledgement. Laura is a second-year general business student at Georgian College, working towards her business and management leadership degree. She is doing her co-op in the Center for Changemaking and Social Innovation. Welcome, Laura.
Thank you, Amanda. While we meet today on a virtual platform, please take a moment to acknowledge the importance of the land which we call home. Georgian College acknowledges that all campuses are situated on the traditional land of the Anishinaabe people. The Anishinaabe include the Ottawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. Georgian College is dedicated to honoring Indigenous history and culture and committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people.
Thank you, Laura. Next, I'd like to welcome Kevin Weaver to come online to give our opening remarks. As Vice President of Academics, Kevin heads up full-time and part-time academic programs at Georgian, as well as our partnership program we deliver collaboratively with Lakehead University and corporate training. Kevin, over to you.
Thank you, Amanda, and good morning and welcome to Rise. It's a pleasure to be with you this morning. It looks like a great day ahead. So Georgian's research program has been steadily growing over the past several years, in particular in the health and wellness area, which is of course our theme for today's Rise sessions. The growth is in part due to the amazing dedicated team of staff, faculty, and students dedicated to excellence in research, but also built on our desire to create impact in our community. About 1 year ago, Georgian's research and innovation team rallied around a very mounting challenge. That was, of course, the onset of the pandemic and getting PPE to frontline workers in our region, where the supply was low or in some cases non-existent. Very quickly, under the leadership of Dr. Mira Ray, the team set up a makeshift production line in our Electra Center for Research, Innovation, and Commercialization and reached out to our local hospitals and health clinics. It was only a matter of days by the time Georgian made PPE made it to those frontline workers that needed it most. You might have read about this in the news. It made headline locally and across the province, and we're so proud of those efforts that the college has taken. COVID-19 has driven so much of the health and wellness research over the past year, but you might be surprised that the types of COVID research projects have been quite varied in scope. Georgian and our community and industry partners have explored topics such as pandemic protocols that help us control the spread of disease, the social and mental impacts of the pandemic on our frontline workers, innovation in PPE design, and the development of biomonitoring technologies, among others. We're so pleased this past year to have developed an even stronger partnership with the Waypoint Center for Mental Health Care. The strength of this partnership was rewarded with 2 research grants from the Natural Sciences and Engineering Council of Canada, both aimed at different aspects of COVID-19 pandemic and the challenges it creates for healthcare workers. You'll hear about some of this work in today's sessions. COVID is not the only story in health and wellness, of course. Our faculty and student researchers have also been focused on clinical medicine and nursing best practices, social work, sustainable development and social innovation, and the effects of climate change on society and our health. Georgian is also working on some exciting health programming. We are on track to launch a standalone Honors Bachelor of Science nursing degree at the Barrie and Owen Sound campuses in fall 2022. And we're certainly really excited about that. Georgian also is participating in the provincial initiative to train 8,000 personal support work. We have 2 intakes of an accelerated program. In fact, one of those intakes started this week and the next intake is in May. So we're proud to be helping with that initiative and supporting our healthcare sector. So let me just welcome you again to Rise. Please enjoy the live session today. There's going to be some great information shared. We also invite you after the live session is over to explore the rest of the platform to learn about all the other research, innovation, scholarship, and entrepreneurship activities that are happening at Georgian. Georgian is proud to be an integral member of the community, working with community and industry partners to drive forward the research, innovation, scholarship, and entrepreneurship agenda. Pleasure to spend a few moments with you this morning. Thank you and enjoy the rest of your day.
Thank you, Kevin. That was amazing. And it's just simply amazing that research is constantly moving and adapting in our changing society. This last year has been troubling and difficult for all of us, but it's just amazing that we have these stronger partnerships with members of our community. And now we're getting expanded programming here at Georgian College. Research of any size has impact on everybody, on ourselves, on our peers, our teachers. And impact is important for us because it allows us to ask the next question in research. Our next speakers are collaborating on research related to the effects of COVID-19 on healthcare providers today, and they'll be sharing their work with you. Our healthcare workers have played an integral part in navigating through this pandemic. It's important to look at the effects of the pandemic on these frontline persons, not only to capture this moment in history, this research history, but to share our experiences and learnings with others. This partnership between Georgian and Waypoint truly demonstrates community and that we're all in it together. Pleased to introduce to you Principal Researcher Dr. Jacqueline Limoges, Faculty of Health and Wellness and Science at Georgian College. Jacqueline is a dedicated researcher, nurse, teacher, and mother. She is active in her community as the Vice Chair of the Ontario Cancer Research Ethics Board, co-lead of the Canadian Nursing and Genomics Group, and volunteers with the Canadian Coast Guard. Her research examines inter- and intra-professional collaboration, the impact of technology on professional practice, and how nurses develop and use their knowledge in practice. She is dedicated to building networks of collaboration for research and to strengthen healthcare and patient outcomes. With over 30 years of nursing experience, Dr. Limoges has partnered with many organizations to support quality patient care and advancements in the nursing practice. Jacqueline, thank you for making change in our community. Joining Jacqueline today and co-presenting the research is Dr. Nathan Kolla. He is Vice President of Research and Academics at Waypoint Center for Mental Health. He is also a forensic psychiatrist. Dr. Kolla completed his undergrad studies and medical school at the University of Saskatchewan. He subsequently undertook a master's degree in sociology at the University of Toronto and forensic mental health science at King's College in London. He has completed general psychology residency at the University of Toronto and fellowship in forensic psychiatry at New York University. Dr. Kolla also completed a PhD in neuroscience, neuroimaging at the University of Toronto. In addition to his research and administrative duties at Waypoint, Dr. Kolla is also a clinician specialist at the Center for Addiction and Mental Health. He has published approximately 70 peer-reviewed articles and book chapters, some in high-impact journals such as JAMA Psychiatry, Biological Psychiatry, Psychopharmacology, and Translational Psychiatry. Nathan, Jacqueline, over to you.
Thank you so much, Amanda, for such a warm welcome. It is truly our pleasure for Nathan and I to be here, showcasing the work that this phenomenal research team has been involved in. So I just want to acknowledge the other researchers, Daniel Anzola and Jesse McLean from RVH. And we would really like to acknowledge the tremendous help from Michelle Dukeman and Jessica Kasdan. They are from Waypoint, and this study just ran so smoothly because of them. So we started out in a partnership with Waypoint, but quickly realized that if we expanded this partnership with RVH, that our research would be stronger, our findings would be more impactful, and that we could extend the collaborative relationships between the three organizations in our community. And so we're very pleased that we were able to do this. I feel that we've really started something great. About a year ago, we all met. Most of us didn't know each other before, but we understood that the pandemic would have a profound impact on the professional practice environment, on healthcare providers, on the health system, and really on every part of our lives. However, we never imagined that we would be here today, a little over a year later, locked down again. But we did understand the importance of pandemic recovery. We understood the magnitude of the pandemic and how it would impact people's lives. So we set out to answer 3 research questions in what is quintessentially applied research. We worked with our partners. We developed these questions together. We tried to develop research questions in a research study that would meet local needs. And we feel that we've succeeded in that, and we hope that you enjoy the presentation to come. What we did is we tried to develop a study around these three central questions. What are the experiences and psychological needs of healthcare providers that have arisen out of the COVID-19 pandemic restrictions? We wondered how the pandemic and the pandemic restrictions would influence professional practice, healthcare providers' relationships with patients, and the inter and intra-professional collaborative relationships, knowing that when we work together effectively, care is safer and more enjoyable for everyone. And then, because this is applied research and we wanted to create an impact, we wanted to understand the education and support needs of healthcare providers so that we could consider very carefully the period of pandemic recovery. So Nathan's going to talk a little bit about the study now.
Thanks, Jacqueline. And just let me echo my appreciation for being here today. It's a pleasure to talk to you all. COVID-19 really created an atmosphere of uncertainty, fear, disruption, and change. Understanding and then addressing the needs of healthcare professionals limit burnout, other psychological symptoms such as depression, anxiety, disillusionment, and can ultimately support an effective healthcare strategy and system. So understanding how the pandemic has influenced professional practice and the practice environment can enable healthcare professionals, health leaders, and policymakers to really offset some of the negative consequences of the pandemic, prevent an echo pandemic. And what I mean by that is mental health problems that have arisen from the pandemic, and to prepare for healthcare needs arising from this pandemic. This study was a mixed method study. And what I mean by that is that it was both quantitative and qualitative. So qualitative means that we got to hear the firsthand experience of participants who participated in interviews with Dr. Limoges during the course of the study. And during these interviews, they were asked questions about how they were functioning, how they felt supported or not in their environments, what they found stressful, and techniques that they thought could be helpful to offset their difficulties and stress during the pandemic. So these were interviews that were conducted virtually and allowed really the participants to speak in their own words. Now, to supplement that information, we also administered questionnaires online. These are questionnaires that respondents or participants answered various scales, and these had to do with anxiety due to the coronavirus, a scale that measured symptoms of depression, anxiety, and stress, a scale that measured work-related quality of life, one scale that measured a person's resilience, so how well they're functioning in the face of difficulties, and then a final scale that measured loneliness that a person might be experiencing. Participants represented a variety of healthcare professionals working at both Waypoint and Royal Victoria Hospital in Barrie. By far, the largest group were nursing staff. However, we also sampled allied healthcare, which would include professions such as social workers, recreational therapists, and we also got the input from physicians as well. Most people were in the age range between 30 and 51. Most people were working on site, the vast majority. It was pretty evenly distributed between how many years they had worked at their respective institutions. So in total, we completed 30 interviews. Again, these were one-on-one interviews conducted by Dr. Limoges and the individual healthcare workers. We gathered almost 90 online questionnaires, and these were questionnaires that asked respondents to write in their answers to various questions. So it was free text where we could get more comprehensive answers to some of our questions. And then we also had 239 different people who did the online surveys and answered the questionnaires. Again, on those scales that measured loneliness, depressive symptoms, resiliency, and anxiety related to the coronavirus. What we found very interestingly is that there were only slight differences between Waypoint and RVH. Now, one important thing to highlight is that participants were sampled at different times. So when we administered the interview questionnaires online to the Waypoint staff, this was last summer. And if you remember, this was a period during which the case count of coronavirus had gone markedly down in the province. And there was also an ease of restriction during that period. In the scheme of the pandemic, it was a relatively good time for us. In contrast, we had measured or collected the data from the RVH staff during the height of the second wave. This was right before the months leading up to Christmas. And so this was when case counts were very high, when there were more severe lockdown measures imposed. And so what we found was that in the RVH staff, they reported more anxiety about the coronavirus compared to the Waypoint staff. And this is not surprising given the differences in the measures of lockdown that differed between the two time points. And also the fact that RVH was seeing active cases of COVID, whereas when the Waypoint staff, who are all psychiatric mental health providers, sampled, they did not have any active COVID cases at the hospital. So what we saw was really kind of a wide distribution of scores, where we found that actually 75% of staff did not have any anxiety symptoms linked to COVID. This was a bit surprising to us, but it showed that on average, people were faring quite well. However, there were about 25% who were experiencing from mild to significant anxiety. So definitely a subset of the group that responded were experiencing clinically significant anxiety symptoms about the pandemic. We found no differences in other scales between the two sites. So the two sites did not differ in the respondents or the participants' depressive levels, in loneliness scores, scores on resiliency. However, what was also very interesting was when we compared the Waypoint scores to other scores taken from populations such as ICU nurses or other healthcare workers, they actually had lower levels of depression, anxiety, and stress compared to these other groups, which we found very interesting. But again, the Waypoint population was sampled during the relative ease of restrictions and at a time when we had no COVID cases in the hospital.
Thank you, Nathan. And so what's really interesting with these mixed method studies is that we can use the participants' own words to help us understand why they might be scoring as they did on these validated psychometric instruments. So you just heard Nathan say that overall people didn't have an incredible amount of anxiety related to COVID on the scale, but when we started talking to people and listening to what they were saying, they did in fact have a real fear of COVID, but they were able to put that in a certain context because of their disciplinary knowledge. So as Nathan mentioned, we used Sally Thorne's interpretive descriptive qualitative method, which is really well designed for applied research projects. And it lets us take in the disciplinary knowledge. So the kinds of things that we at Georgian teach our students. The participants understood how to protect themselves with PPE. They understood infection control measures. And so that helps them to have some sort of containment of their fear and anxiety. But nonetheless, we heard regularly, that COVID fear is real and it is challenging. But what it really played out as is that it created a tremendous blurring of boundaries between home and work. So the participants talked about being really concerned about bringing COVID home and really concerned about bringing COVID to the hospitals. And so we know that in terms of mental wellness of healthcare providers, the inter-shift rest period. So when you leave work and you go home and you have a rest period, it's really important that that is a period of time off. But because of these concerns for contagion and the social isolation as well, it made it quite difficult for people to really get that deeply restful time off. So that intershift period became a concern. So the other that was interesting is this notion of heroes to zeros. So back to when we think about the fear of contagion. In the early pandemic period, healthcare providers, people were clapping for them and people were dropping off all kinds of, lovely treats and rewards. But as the pandemic wore on, we heard more and more from the participants saying that they were experiencing social exclusion. So again, that intershift period became challenging. People were nervous to be around them for fear of contracting COVID. We heard stories of, people didn't want their children to play with the children of healthcare providers and so so on. So the dynamic really started to change, really adding to some of the emotional suffering. So the finding that is really important when we think about the impact of the pandemic is this notion of empathy strain. So we teach healthcare providers to have empathy. We cultivate empathic responses. We talk a lot about it in school. It's really an important feature of a therapeutic relationship between a healthcare provider and a patient. But when there's so much empathy, it can actually create a strain. So if you recall, in the various periods of the pandemic, patients weren't allowed to have their family or visitors around. In the psychiatric facility, the patients had limits in terms of group therapy. They couldn't go to the canteen. They couldn't walk the grounds. They had to sort of stay in place like the rest of us. But when you're a patient in a facility, the mobility restrictions that we've all been living with for quite a while have a really strong impact. So what it meant is that the healthcare providers were the only source of support and contact for the patients. And witnessing the impact of this on patients was really profound and created a lot of strain. As we spoke to, these 30 healthcare providers and read 88 of their handwritten notes to us, we could really understand how witnessing the impact of the pandemic on the patients really became a dominant part of their experience and really difficult.
So this just speaks to the point that I made earlier, that there were really no differences in sites in terms of resiliency and quality of life scores. So Waypoint staff did not differ on these measures from the RVH staff. And as we mentioned before, both sites were faring better than some of their comparison sites in the medical literature. So again, these were ICU nurses or prison nurses or other healthcare staff at academic centers. So that again was a little bit of a surprise for us. When we did a regression analysis that looked at whether there were predictors of greater resiliency or greater quality of life, what we found was that the nursing profession was one significant predictor of having more resiliency and having better quality of life. And this is the nursing staff compared with the allied healthcare staff and the physicians. One way we can interpret that is that compared to other allied staff, nursing staff were less likely to be redeployed. They were a necessity in their various roles, and so they were not redeployed. And in that way, there was less of an atmosphere of uncertainty compared to other professional groups who were at risk of being redeployed and had less control over their environment. So that was one reason why we thought nurses scored better on those two measures.
When we turn to the qualitative data, we can start to see this understanding of how the work environment was changed and really quite dramatically changed by the pandemic and the pandemic policies. So Nathan just spoke about redeployment, how many of the allied healthcare providers were required to assume different roles. But what this did is it created an interesting dynamic that I'll speak to in a moment. What the healthcare providers in our study recognized is that they could have more quality of work life. They could have less stress and anxiety if they could improve the patient's living arrangements. So when we asked them, how could we make this better? How could we make work less stressful? They spoke about the need to do things differently. They spoke about how in the initial pandemic period, everybody was kind of gung-ho, let's lock it down, let's really contain this. But when they started seeing the impact on patients, they started to realize this is really creating harm. So while we're limiting the spread of COVID, we're creating other sorts of harm. And witnessing that in the patient then creates harm in us. So they started to look at how could they enhance their work life? How could they enhance their resilience? And it was really around exploring alternate ways of offering therapeutic services. And as we've been talking about, this redeployment created a really interesting dynamic. For those of you interested in inter and intra-professional collaboration as I am, one of the important features is for people to understand the roles of other people, to understand the contributions that they make to patient care. And what really started happening is that as people were floating, as people were redeployed, the team started to develop quite a strong sense of community. They started to understand each other's roles more, either because the role was no longer offered because somebody had been redeployed, or noticing, well, what happens to the patients when we don't have recreation therapy in the same way that we did, or when we don't have volunteers visiting, or other kinds of supports. So it was really an opportunity for people to start to come together and really develop a new appreciation and respect for each other. And I also wanted to mention some of the issues around policy communication and implementation. So when we looked at the differences in terms of the quality of work-life scores that Nathan spoke about, when we interviewed the allied health professionals, we heard a lot of accounts of the pandemic pay policy and how that had an inadvertent negative effect in terms of who got pandemic pay and who didn't. And that actually created quite an interesting mindset in terms of who is an important part of the team and who isn't. And even though the pandemic pay was only offered in a period of the pandemic, it went on to have quite a lasting effect in terms of a person's attachment to their work and their value. So the other part that was impacting the quality of work life was really around the policy communication and implementation. There was and there still is a constant change in policy, and the way that these are communicated is having an impact on healthcare providers. It makes them uncertain in terms of, well, what are we supposed to do? Because on one day, a certain practice is acceptable and they're told that this is a safe practice, and then the next day the policy changes. And again, some of the policies they perceive to be overly restrictive, and they're not always sure how the implementation of the policy in that way is achieving the maximum good and the minimal harm. So it was really interesting how the policy also impacted their work life.
And so this just underscores the point again that there were no differences in loneliness scores between the RVH workers and the psychiatric mental healthcare staff at Waypoint.
It was interesting. Again, when we listened to participants, we heard stories about the taken for granted social support that was just part of everyday work before the pandemic. Having lunch together, having break together, casual conversations in the hallway as people passed, with the need to maintain the 6-foot distance between people. That sort of camaraderie and social support was really lacking, and it was really impacting the well-being of healthcare providers. And they talked about work feeling like more and more of a grind.
Right. All this slide shows is that when we looked at the different groups of healthcare providers at RVH, so medicine, surgery, pediatrics, there was no difference in any of the scores between the different patient care groups. So what we recommend is that an understanding of the sources of stress can really advance conversations and planning with staff, which is of paramount importance to the health and well-being of staff. And acknowledging the benefits of empathic responses like Jacqueline talked about, and supporting staff to cope, maintaining healthy boundaries, and avoiding empathic strain is key to keeping our healthcare workers safe and productive. We need to recognize the stress and sacrifice of healthcare providers and provide positive ongoing reinforcement. And it's also important that our healthcare providers are brought to the table to assist and give voice to development of policies, implementation of these policies, and evaluation of them.
We engaged in quite a hearty knowledge translation phase to this study. And this slide kind of shows the overview. At every instance, we communicated the findings to participants. So once we would finish one phase and we would analyze the data, we would send out these infographics to participants so that they would have a chance to work with it. Remembering that one of our findings was that healthcare providers need to talk about their experience. So these infographics could be used by health leaders or team leaders or different staff groups to really ask, does this resonate with us? What does this mean for us? We also developed what we call a huddle doodle video, where we partnered with the other COVID study at Waypoint, the study on mindfulness, and we presented the empathy strain finding from our study and followed it up with a mindfulness practice around really sort of self-compassion, which is an antidote to empathy strain. And so that little doodle video is now being shown. We've been distributing it and people are using it, and we're hoping that they're finding it helpful. We will end here on this slide with some questions where, we have this at the beginning, this COVID chasing the person, and at the end where we see we will get through COVID and we will need to pay very close attention to a recovery period for healthcare providers who have really been under a tremendous strain. Even in the periods where there was low COVID, that looming sense of the pandemic impacted people. And so we'll open it up now to your questions.
Thank you so much, Jacqueline and Nathan. That was such an amazing presentation. And I love mixed methods research. I think it's just the perfect complement of having a little bit more context to those scales that we do use, that we do need some concrete numbers for. So we have time for 2 questions. One of them revolves around like a longitudinal design. Do you foresee following up with this population in the next little bit or a post-pandemic just to see what the difference is?
And it is great. And actually, one of the recommendations that we've been writing about in our publications is that it would really be a good idea for health facilities to have a regular check-in using standardized assessments so that they can assess the well-being of their staff to see whether the strategies that are being implemented make an impact. We could certainly do this again. It would be interesting, when we're all vaccinated and the restrictions are easing, to see what's happened. It would be very interesting to see how people are faring. And when we move out of this period of exhaustion and burnout and loneliness.
And just one last question. I know research on this topic is probably limited just based its current, it's a hot topic, but do you know of any other studies that are happening right now in other parts of the world? And are they having findings similar or different to what you guys are measuring?
I can speak to that. There was one study that was recently published in The Lancet Psychiatry, which is a very prestigious journal, which found that about a third of patients who had been exposed to the coronavirus, so who were infected, but then subsequently got better, had mental health difficulties subsequently. So depression, PTSD, anxiety. So it just goes to show that beyond the respiratory symptoms and the physical symptoms of COVID, we're going to have to be on the lookout for psychiatric and mental health care symptoms in people who have been exposed and infected with the COVID virus.
Great point. I want to thank you both for joining us today and for that amazing presentation. And just a reminder, there's lots of mental health resources out there, not just for healthcare workers, but just for people here at the college or students or faculty. So check out GCSA or the EAP program. We're not alone, and it's better to talk about it and share our discussions and experiences from that. So thank you so much for joining us.